Hello, and thank you for coming to my presentation. My name is Alyssa Marso, and I will be presenting my Doctor of Nursing Practice project for the Catherine McCauley School of Nursing at Maryville University. The title of my project is Screening for Depression and Anxiety in Students on College Campuses, a Quality Improvement Initiative. First and foremost, I would like to acknowledge Dr. Linda Studley, my chairperson throughout this doctorate program. Her wisdom and guidance throughout this project were invaluable and did not go unnoticed. Additionally, I would like to thank every member of the doctorate program who assisted in guiding me in the success of this project, specifically Dr. Lisa Stewart, the second reader of this project, as well as my community buy-in for this project, Dr. Chrissy Hall Sims. The focus of this DNP scholarly project is to screen college students with PHQ-2 and GAD-2 screening tools at every encounter at the campus health center to determine if the number of students who obtain referrals for psychiatric services increases compared to the number of students in psychiatric services before screenings. Patient Health Questionnaires, or PHQ, and Generalized Anxiety Disorders, or GAD, screening forms are self-reporting tools that are utilized to determine if the patient has experienced depression or anxiety symptoms over the last 2-week period. Screening tools such as a PHQ-2 and a GAD-2 are effective and quick ways to evaluate for depression and anxiety. After screening for these conditions, appropriate referrals can be made to psychiatric services for further evaluation and treatment plans. Depression has been on the rise among college students. 39% reported feeling so much depression that it made it difficult to function. Within that same survey, 10% said they had even considered suicide. Screening for anxiety and depression is crucial to providing primary mental health care to students on college campuses. Implementing a screening tool for anxiety and depression would assist in identifying students who may benefit from behavioral health or psychiatric services. There are various screening tools to choose from. However, finding one that is efficient and effective for both the student and the institution is essential. The United States Preventative Services Task Force draft for 2022 suggests screening all adults 64 years old and younger for anxiety and depression at every healthcare visit. I have always been passionate about working with young adults that are entering uncharted seasons of their lives. While I have a desire to decrease the stigma associated with mental illness, combining these two while working at a college university as a psychiatric mental health nurse practitioner led me to seek a project topic to combine both of these interests. When I started working at the university, I noticed that not many students were utilizing psychiatric services, but were instead using family practice for symptoms such as difficulty sleeping, poor appetite, anxiety, irritability, difficulty concentrating, and feeling fatigued. These can all be symptoms of depression and anxiety that often get pushed onto other illnesses rather than the main culprit, mental health. When discussing these findings with my colleagues, it was thought that possibly the students didn't realize their symptoms were related to depression and anxiety. Some students get placed into a probationary period within the university academics department for various reasons, including tardiness, declining grades, poor attendance, and other adverse outcomes. I saw this as an opportunity to implement depression and anxiety screenings to assist the students prior to the decline in their academic and mental health. Throughout the timeline of this project, all students who enter the campus health center for an appointment, regardless of their chief complaint, should be screened for depression and anxiety with the overall hope of reaching more students and bringing awareness to their mental health. As someone who believes in providing education about mental health treatment and prevention options to students, screening for anxiety and depression is a quick and accessible method for early detection. More than 60% of students had symptoms of one or more mental health disorders in 2020 and 2021. Depression is a mood change, often sad, resulting in at least 2 weeks or more, including difficulty sleeping, irritability, decreased concentration, anxiety, or hopelessness. Anxiety is a psychological response to the present situation, which can be described as difficulty concentrating, trouble sleeping, daily fatigue, racing thoughts that are difficult to control, and restlessness. The increase in depression and anxiety amongst college students is thought to be multifaceted, including changing living situations, the pace of life increases, studies that become more demanding, and distance from families are just some of the straining factors. The occurrence of depression in the general population is observed to be around 9% and is much higher for students on a college campus at 30.6%. The prevalence of anxiety is between 63 and 92% on college students. Two screening tools are widely used to screen for depression in adult patients, a PHQ-2 and a PHQ-9. The PHQ-2 is a two-question assessment with similar sensitivity to the more in-depth PHQ-9. The specificity when using a PHQ-9 is greater at 91 to 94%, whereas the PHQ-2 specificity is 78 to 92%. After completing the PHQ-2, if depression is suspected, a more in-depth PHQ-9 is concluded for a more specific assessment of depression. Anxiety is considered normal on some level. It's how we keep ourselves safe. A generalized anxiety disorder differs from someone who feels anxiety during a high stress or situational event. Multiple scales and tools have been developed to assess anxiety in patients. The most common ones used are a G87 and a G82. The G87 is a 7-question tool based on the criteria for anxiety disorder according to the Diagnostic and Statistical Manual of Mental Health Disorders 5, or the DSM-5. The G82 consists of the first 2 questions in the G87, which highlight the key symptoms of anxiety. The G82 has a sensitivity of 76% and a specificity of 81%. The G82 is a validated tool used to be the first step in assessing anxiety. With the cutoff score of 3, further evaluation using a G87 would be warranted. This scholarly project's purpose is to implement a quality improvement initiative with an evidence-based focus to use standardized screening for all students who receive services at the University College Campus Health Center by having nursing staff complete the PHQ-2 and G82 screening tools at the start of every student encounter. Implementing this initiative intends to decrease the prevalence and negative effects of depression and anxiety in college students, assist in proper treatment, improve student outcomes, and facilitate acceptance of mental health concerns by exposing more students to the resources and access to mental health care. Access, acceptance, and treatment of depression and anxiety will decrease additional comorbid conditions and increase productivity and academic success. With scores greater than 3 collected from the screening tools, appropriate referrals to psychiatric services will be placed for evaluation. Prior to this initiative, no current screenings were being completed for anxiety and depression unless the student was already under the care of a psychiatric nurse practitioner. By the age of 14 years old, 50% of the lifetime mental illness begins. By the age of 24, it is 75%. On average, there's an 11-year delay in getting an accurate diagnosis and treatment plan. Developing this project to implement screening with a PHQ-2 and a GAD-2 will assist in bridging that gap in mental health care treatment. Review of literature. During the review of literature, there were 4 main themes found: risk factors for depression and anxiety, screening tools, experience barriers, and interventions. Risk factors for depression and anxiety. The changes to daily living, such as the increase in workload, social demands become more intense, the fear of disappointment by self, family, institutions, the distance from families, increases in academic pressure, such as deadlines for large projects, learning how to balance increased coursework, and pressures from teachers, peers, and parents are all factors that increase the risk of depression and anxiety. Risk factors are not always environmental changes that occur when someone goes to college, but also should include family history, personal trauma, personality traits, and unpleasant experiences. Increased sedentary behaviors such as reading, studying, computer games, mobile phone usage, and television have increased psychological stress. Having additional responsibilities such as working and various activities can add to the mental distress felt by students on campus. At this developmental stage in a young adult's life, they seek independence and autonomy, resulting in hesitancy to ask for help. Screening tools. Various screening tools are approved and utilized to detect depression and anxiety. The essential aspect of implementing a process is to be consistent with the tools used and that it is a valid tool. The validity of an assessment tool is based on the accuracy with which the device can measure the outcomes being assessed. Some studies utilize the Beck Anxiety Inventory and the Beck Depression Inventory to screen for depression and anxiety. The Center for Epidemiological Studies Depression Scale is another self-reporting screening tool that can be utilized. The CESD is a 20-question measure to assess depression over the last week. The Depression Anxiety Stress Scale, or the DAS-21, is a 21-item questionnaire that assesses feelings over the last week. While all of these tools are valid and they have a multitude of questions that require a greater amount of time than is allotted for most healthcare visits. Completing the PHQ-2 followed by the PHQ-9 is a valid way to screen for depression. The PHQ-2 evaluates the frequency of depression, mood, and lack of enjoyment, which are the first 2 questions of the PHQ-9. If a score of 3 or greater is obtained, then completing a more in-depth PHQ-9 is to conclude a diagnosis of depression is warranted. To screen for anxiety, the tool started with a GAD-13. It was then shortened to a GAD-7 and now has been compressed into a GAD-2. The GAD-2 evaluates anxiety by screening for the core symptoms of symptoms concerning anxiety. The GAD-2 is often completed to combat time constraints, and then the GAD-7 is followed up if anxiety is suspected. The GAD-2 is of similar validity to the GAD-7 and focuses on nervousness, feeling on edge, and being unable to stop the worrying over the last 2 weeks. Experience barriers. Surveys determine that cultural bias and surrounding stigma are considerable barriers for patients seeking mental health care. Examples of the factors that may be a hindrance to obtaining proper treatment are being of a different race or ethnicity rather than white, having a single or minimal income, having a single lifestyle, smoking, drinking alcohol, or decreasing exercise all increase the risk of anxiety and depression. Symptoms of depression and anxiety, such as crying and sadness, are not considered masculine in some cultures, decreasing the rate of reporting these ailments and ultimately decreasing the number of men seeking treatment when these patients were asked. Personal stigma, public stigma, and less than desirable provider availability decrease the ability for patients to obtain treatment. Barriers for students to access care for depression and anxiety are often the reason illnesses go untreated. Those barriers include financial stress, scheduling conflicts, difficulty securing a provider, inconvenient locations, personal stigma, and feelings of shame. When completing interviews, students did not associate their feelings of overwhelm with depression and anxiety and perceived the stress levels as usual or expected, which decreases the urgency to seek further evaluation. Reasons for not screening included a lack of providers to send the referrals to, the financial burden placed on patients, reluctance from providers for change, and the increased time required to spend on screening tools. Concerned about a liability if the screening was positive, but there was an inability to find a psychiatric provider to continue the care and decrease clinical space. Interventions. In some reviews, a psychiatrist was brought into the same office as a primary care provider to assist patients. This addition to the office reduced the perceived stigma of others knowing why one was in office, and the scheduling staff assisted in making referrals. Having a shared office space decreased the need for patients to find a different location, and communication increased between providers. Once barriers were reduced for patients to have access to mental health care, the literature indicated that 43% of patients who were referred to psychiatry did attend at least one visit. Using a PHQ-2 and a GAD-2 as tools decreased the questions from 16 to 4 total questions. The decrease in the number of questions assisted the staff in feeling less time constraints by allowing for less of the allotted appointment to be spent on the screening tools. With sensitivity and specificity of the PHQ-2 and the GAD-2 being compared to those of the other extensive screenings, filtering out which students require further evaluation saves resources. The theoretical framework that best exemplifies the focus of the STEAM project is Orum's self-care deficit theory. At the most basic level, Orum's theory is that people want to take care of themselves and can improve their health more effectively when encouraged to do so for themselves. Oram took her knowledge and began searching for an understanding of nursing as a practice in applied science. She acknowledged the structure of nursing as a discipline of expertise assisted in overcoming issues that arose and set forth to develop the self-care deficit theory. The foundation of her theory is self-care, deficit, and agency. She describes self-care as what people do to care for themselves for function, well-being, and health. Self-care agency is when one can achieve self-care. Conversely, a self-care deficit is when one cannot meet their demands appropriately. She felt that primary care needs to maintain life are food, water, air, elimination, activity, rest, social interaction, privacy, safety, and acceptance of normalcy. In her theory, she describes that nursing care is needed if one cannot meet the needs and is experiencing a self-care deficit. She identified self-care requisites, which she then separated into 3 subcategories to describe the needs that individuals need to have met. The first category is universal self-care, meaning everyone shares the exact same requirements, such as food, air, water, safety, activity, and rest. The second category is developmental, further divided into maturational and situational. Maturation is the patient's progress in maturing, and situational prevents harm effects during development. The third is health deviation, which is noted when the patient's condition changes. When a patient cannot have self-agency, the nurse provides support. Depression and anxiety would be part of the third requisite in her self-care deficit theory, as it is based on health deviation. The requisite focus is when a condition or health status changes, including mental health. Experiencing depression or anxiety exacerbation would be considered a condition change. Orum's self-care deficit theory can be applied to many areas of nursing, including the STMP project. When students are experiencing symptoms of depression and cannot fulfill their daily activities, nurses can step in and provide total or partial assistance, education, and support with permission from students. Assessing at which level the student cannot offer self-care will allow the nurse to know how much aid is needed to make a referral to psychiatry and obtain follow-up appointments. Regardless of their chief complaint, students who utilized the Student Health Center during March 11, 2024 and April 11, 2024 were to be screened with a PHQ-2 and a GAD-2 screening tool as part of the standard triage process. If the score of 3 or greater was obtained on either tool, a referral to psychiatric services was placed with the student's consent. No recruitment was required as all students who receive care at the health center do so on a voluntary basis. All student identification was removed from the data collection sheet. I developed this data collection sheet for this QI project. This is a sample of the sheet. The student arrives to the health center for an appointment to see a provider for any chief complaint. During the already routine triage and history taking completed by nursing staff, PHQ2 and the GAD2 screening tools are completed. After the screening tools are completed, the APRN that is conducting the visit for the chief complaint will assess the student for the appointment, review the scores, and discuss the option for a psychiatry referral if there's a score of 3 or greater with the student. If the student agrees to referral, the provider assists the student in making the referral appointment. After the data collection period was completed, a quantitative retrospective chart review was completed to determine if the screening students with a PHQ-2 and a GAD-2 screening forms increased the number of student referrals to psychiatry during the project's timeframe. The inclusion criteria for this project included documentation that the student is 18 years or older. The student must currently be enrolled to the university to have the ability to utilize the Student Health Center services. The student chart contains documentation that the student was seen at the health center during the project's timeframe. This project will include students of all genders, races, ethnicities, and spoken languages. The exclusion criteria for this project include chart documentation that the student is under 18 years old. The student was not enrolled at the university during the project's timeframe, or the student's visit did not conclude during the project's timeframe. The data for the study sample was obtained during the retrospective chart review and collected on data collection sheets in the previous slide. The age range of the students who participated in the project is 18 to 49 years old. Most students were 19 years old, and all except 2 were 32 years or younger. There was one student who was 36 years old and one who was 49 years old. Students in the study were classified as male, female, or other. For this study, the student's biological gender was utilized. The retrospective chart review indicated that 152 female and 107 male students utilized the Student Health Center during the data collection period. First-year students encompassed 10% of the students who participated, and the class with the most significant number of students was the graduate level at 45%. 6 students were listed as unknown on their academic year classification. 4 different races were collected during the retrospective chart review. The races were Asian, Black, unknown, and white. The predominant race was white students at 42%. Next, the most common race was unknown at 32%. The other races were Asian and Black at 14 and 12% respectively. Part of the data collection was to determine if the students were already in psychiatric services. Out of the 259 student encounters, 5% were active in psychiatric services. 247 students were not active in services at the time of the data collection. It was discovered that 52% of the students were screened during their encounter, while 48% of students were not screened. The descriptive statistics used in this project were the results of the PHQ-2 screening, the results of the GAD-2 screening, age, gender, race, academic year, if the student was in psychiatric services prior to the screening, if the student accepted a referral to psychiatric services, and if the student was screened using a PHQ-2 and a GAD-2 during their encounter. There is not a statistical test to be completed as there was not previous screenings being completed prior to this project implementation. The results of the PHQ-2 and the GAD-2 screening tools are considered interval data, where there is a possible score of 0, as well as the possibility that 0 students who scored positive on a PHQ-2 or a GAD-2 screenings would have accepted a referral to psychiatry services, as this had not been conducted at the University Health Center previously. Using a retrospective chart review, it was determined that 3 students met the criteria and accepted a referral to psychiatric services after having a positive screening. Data was collected in all 259 student encounters from March 11th, 2024 to April 11, 2024. Of the 259 student encounters, 125 did not complete the PHQ-2 or GAD-2 screenings. Of the 134 encounters screened using the PHQ-2 screening tool, 12 students had a positive result of 3 or greater on the PHQ-2. 23 students had a positive result of 3 or greater when screened with the GAD-2 screening tools. Of the 3 students who accepted a referral to psychiatric services, 1 student obtained a PHQ-2 score of 4 and a GAD-2 score of 2. The second student obtained a PHQ-2 score of 4 and a GAD-2 score of 4. Student 3's PHQ-2 result was 5 and their GAD-2 result was 6. The students who did have a positive result but declined a psychiatric referral were educated on the resources available to them at the University Student Health Center. During the administration of the PHQ-2 screening form, 93 students scored a 0 on the screening, 18 scored a 1, 10 students scored a 2, 5 students scored a 3, 4 scored a 4, 3 students scored a 5, and 0 students scored a 6. During administration of the GAD-2 screening form, 71 students scored a 0, 22 students scored a 1, 16 students scored a 2, 5 students scored a 3, 7 students scored 4, 4 students scored 5, and 7 students scored a 6. Demographic data was obtained from the 3 students who accepted as psychiatric referrals as a direct result of the screening form implementation at the University Student Health Center. All 3 students were female, 2 students were 19 years of age, and 1 student was 23 years of age. The 3 students' academic years were first year, second year, and senior. The main limitations of this project was the inability to screen every student for various reasons, including time constraints, new staff at the health center, and the need for further education regarding the subject matter. The original plans for this project were for every student who utilized the health center to be screened using a PHQ-2 and a GAD-2 at every visit. Throughout the time frame of the project, there were 125 students who were not screened. This quality improvement initiative implemented in the University Student Health Center would benefit the students and staff if it were continued for current and future students who attend this university campus. The overall hope for the future of this initiative is that mental health of students would continue to improve via being screened, detected, and treated prior to adverse outcomes, increase in communication and awareness of the staggering mental health crisis university campuses are facing, and decreasing resistance or stigma related to mental health treatment. When students are working through enrollment, adding a PHQ-2 and a GAD-2 screening forms to be completed and then forwarded to the University Health Center for review will be a topic for future research. This will provide a larger population sample and a baseline for students' anxiety and depression screenings prior to environmental stressors of attending university. Anxiety and depression are mental health illnesses that have been burdened many students on university health campuses and may result in adverse outcomes. The focus of this hypothesis of this scholarly project was to determine if screening students who utilized the University Health Center with a PHQ-2 and a GAD-2 screening form at every visit, and if positive result was obtained, to send a referral to psychiatry for further evaluation to determine if more students utilize psychiatric services after having the screening completed. This is true. There were 3 students who had a positive result and accepted referrals to psychiatry. Providing depression and anxiety screenings to every student who utilizes the University Student Health Center is an effective way to detect anxiety or depression. This quality improvement project positively benefited the students at the selected university. The results of this initiative provided an opportunity for students who screened positive to have further evaluation after having open dialogue conversations with their primary provider regarding their screening results. Without the screening, these students may not have reported their anxiety or depression symptoms and therefore are unable to obtain evaluation and treatment properly. Preventative screening for depression and anxiety at every visit with every student allows for appropriate resources to be utilized prior to adverse outcomes for the student. The recommendation is to continue to provide consistent screening with the PHQ-2 and a GAD-2 screening forms at every student visit and provide further evaluation if warranted. Continuing with the implementation of this quality improvement initiative will provide an increased quality of life to the student population while on the university campus and throughout life. If you have any questions, concerns, or suggestions regarding this DMP project, please feel free to reach out to me with the email address listed. Here are the references I utilized during my DMP project. Thank you for watching my video. And again, thank you to my community members and my doctorate support staff.